I'd now like to introduce our next speaker is Dr. Anne O'Neill, also at University Health Network, and she's going to talk about autologous reconstruction, which is also reconstruction using your own tissue. Dr. O'Neill completed her training in plastic and reconstructive surgery in Ireland and was awarded a fellowship of the Royal College of Surgeons. Having also studied at Harvard Medical School, we have really quite a scholarly group here tonight. We are very fortunate that Dr. O'Neill came to Toronto to do a fellowship to gain specialist training in microvascular surgery, microvascular oncological reconstruction. Dr. O'Neill's specialist interest is microsurgical cancer reconstruction and autologous breast reconstruction, which she will talk about. So her talk is going to follow the same format. She's going to do an overview of autologous or tissue-based reconstruction. Then she's going to present her patient's case, which is a DIEP surgery. And then her patient, Jamie, will come out and talk about her decision and her experience. So I'd like to welcome Dr. O'Neill.
Thank you, Natalie, and thank you all for coming out this evening. So I'm going to talk to you about autologous breast reconstruction. Autologous breast reconstruction simply means making the breast shape from your own body tissue, usually skin and fat. And it's also referred to as a flap reconstruction. So usually when we talk about autologous breast reconstruction, we mean that the entire breast shape is made using your own tissue, and we do not use a breast implant. So the commonest place that we take this skin and fat from is from the lower abdomen. And that's simply because that's the place where we all have a little bit of extra skin and fat that we're pretty happy to donate. If you feel your lower tummy, it actually feels quite like a breast. It's nice and soft, and it has a very similar consistency to breast tissue. It's also a really handy place for us to tuck the scar away. It gives you a scar on your lower tummy, which is not unlike the type of scar you get with a tummy tuck. So it's a good place to hide it. And the last reason that we like using tissue from your lower tummy is that for technical reasons. It's a flap that's the one we use most commonly. The anatomy in that area is quite consistent, and it makes it easier for us to access it during the surgery because it's on the front of your body, just like the breast that we're reconstructing. So I'm not going to give you too many details about the surgery itself, but I am going to describe 3 different flaps that we can take from your lower tummy, because this is something that some of my patients are often quite confused about when they've done a little bit of reading by themselves. So when we first described using your lower tummy tissue to make a breast, we were performing what we call a pedicled tram flap. And that meant that we were taking the skin and the fat from the lower tummy, and we were leaving it attached onto the rectus muscle on one side. Your rectus is your six-pack muscle, and that entire muscle was being harvested with the skin and fat, and we were swinging it up into the chest. So the muscles stayed attached at the upper end. So that was how we got it up into the breast area. So that surgery was a great revolution in breast reconstruction, but it did have some problems. The first problem is that we have to take away the entire rectus muscle if we do this. The entire length of the muscle is taken with the tissue. And the second problem is that we're depending on the blood vessels that come into the top of the muscle. And those blood vessels are not the big main blood vessels that supply this tissue at the bottom. So that was limiting in some way the amount of tissue that we could move and rely on when we brought it up into the breast. So that brought us to the second evolution of this surgery. So we were thinking that it would be much better if we could use the blood vessels at the lower part of the abdomen, because these are bigger and they're a much more direct blood supply to the skin and fat of the lower tummy. But obviously we can't swing this tissue from the lower tummy, so we have to completely disconnect this tissue. So we're still taking the rectus muscle underneath the fat and the skin. We're detaching the blood vessels down here in the groin area and reattaching those blood vessels to blood vessels that run behind your ribs in the chest. So this is called a free flap because it's completely detached and reattached. So this solved one of the problems in that we were able to have a greater volume of reliable tissue when we moved it up into the chest, because we were now using the most important blood vessels that supply the skin and fat. But we still had the second problem. We were still taking this piece of muscle out of the rectus. And we didn't really need that muscle. We don't use that muscle as part of your reconstruction. It doesn't contribute in any meaningful way to the breast that we make. We only take that muscle because the little blood vessels that supply the skin and the fat are passing through that muscle. So we just take them as a way of getting those blood vessels with our flap. So then we thought, why don't we try to take out those little blood vessels and tease them out of the surrounding muscle so that we can leave the muscle behind. And this is the most modern evolution of the abdominal flap reconstruction, where we take the skin and the fat and we take these small blood vessels and tease them out of the rectus muscle so that we can leave almost all, if not all, of your rectus muscle behind. Then we do it the same way as with the free tram. We trace these small blood vessels back to the bigger vein and artery and completely disconnect this tissue and reconnect it to blood vessels that run behind the ribs. So this is what it looks like from the front when we take those small blood vessels that are running into the fat and we're leaving the muscle behind. We do open the covering of the muscle and we split the muscle so that we can take the blood vessel out. But in most patients, we're able to leave all, if not the majority of this muscle behind. And then this tissue is disconnected from the abdomen and reconnected to blood vessels that run behind the ribs. So that allows us to move a maximum amount of skin and fat up into the chest for the breast reconstruction while preserving the integrity of the abdominal wall. And this is the technique that is our preferred method for autologous breast reconstruction in patients today. The second thing that it's important to understand if you're undergoing an autologous breast reconstruction is differences in the timing of reconstruction. So we talk a lot about immediate reconstruction and delayed reconstruction. And immediate reconstruction means that we do the reconstruction on the same day as the mastectomy. If the reconstruction is not done on that day, then it is by definition a delayed reconstruction. It doesn't matter if you have it done a month later or if you have it done 10 years later, that is a delayed reconstruction. And I'll show you with some pictures later on that whether you have it as an immediate reconstruction or a delayed reconstruction can affect how it looks afterwards. And sometimes people find that a little bit confusing when they look at pictures of patients on the internet. They're not sure why they look so different. So this is an example of a patient who has right-sided breast cancer, and she underwent a right-sided immediate breast reconstruction. So when we perform the reconstruction on the same day as the mastectomy, the breast surgeon will leave the skin of the breast behind. So all we really need to reconstruct is the filling of the breast. They've left the breast skin there, so that's all left as it was before. So you can see that there's a very small pale patch in the center of the breast, and that's the skin from the abdomen. So that's the only piece of abdominal skin that we see in an immediate breast reconstruction. This is another patient who's had an immediate breast reconstruction. We can see this is a much slimmer patient, and this is one of the nice things about having an autologous breast reconstruction using your own tissue. Your own tissues tend to match quite well to the breast size that you have. So if you're smaller, it will reconstruct a smaller, thinner breast. And again, you can see the small patch of abdominal tissue visible on the right side. This is again a bilateral reconstruction, and you can see the two small patches, but the skin envelope or the covering of the breast is all left behind at the time of the mastectomy. This is a patient who didn't like their original breast shape, so they asked us to change that shape a little, which we're also able to do. So even though one of the big advantages of an autologous breast reconstruction is it can give you a very natural shape that's very similar to your own breast on the other side, if you want to change the breast shape, then that's still possible. We have a lot of options with molding and shaping the breast, and that's something that you can discuss with your surgeon beforehand. In delayed reconstruction, we're not just making the filling of the breast, the covering is also gone. So we have to kind of make the envelope and the filling. So if we look at this patient, this red line is where her mastectomy scar is. And sometimes when I'm explaining to patients that she's missing skin from her breast, that's a difficult thing to understand because people look at their chest and think, I'm not missing skin. But what we mean by that is if you look at the breast on the other side, everything below that line, that nice curve that we see below that line on the other side, that skin is missing. So we have to get that skin from somewhere. So if you're having an implant-based reconstruction, we get that skin by stretching the skin on your chest. But if we do an immediate breast reconstruction, we're able to get that skin from your abdomen. So in the case of a delayed breast reconstruction, we can see that there is much more abdominal skin on show. So out of clothes, it does look different to an immediate breast reconstruction. But it means that we can bring in nice, healthy tissue. A lot of patients who come to us, they'll have had radiation, and it's very difficult to stretch radiated skin to create that breast shape. So using an autologous reconstruction has the advantage that we're not relying on tissue that's been damaged by your previous treatments. We can get tissue that's been out of that field and we can bring that in to make the shape. This is an example of a patient who's had a right-sided mastectomy, and you can see that her scar is visible on the top. There's nothing we can do about your mastectomy scar. We just have to incorporate that into the new breast. And then we can use abdominal skin to create a very natural breast below that scar. And this is after nipple reconstruction and a small lift on the left side. This is a patient who's had a bilateral delayed reconstruction, and you can see that we've used quite a lot of abdominal skin to recreate that natural shape of the breast. And this is a good picture to show the abdominal scar. It is quite a large scar that runs from hip to hip, and also a scar around the belly button. But this scar on the lower abdomen is well hidden in clothes for most patients. So when people come to my clinic, they're always asking if there are pictures. People love to see pictures, but I always remind people that women and breasts and mastectomy scars come in all shapes and sizes. So when you look at pictures, nobody looks like you before their surgery, and they're not going to look like you after their surgery. So while it's helpful to give you an idea of what your reconstruction will look like, it's important to remember that it will look very different on you. So when I meet with patients who are considering a breast reconstruction, like Dr. Zong said, one of the most important parts of the consultation is working out what you hope to achieve from your breast reconstruction. People's goals and expectations are very different. Some patients want the very best reconstruction that they can possibly get, so they look their absolute best and it feels the best, and they look the best in and out of clothing, and it's a great match to the other side. But other people just want to not have to wear a prosthesis anymore. So people will come with very different ideas about what they want to get out of this. And breast reconstruction is a shared decision. We can advise you on what we think would be a good reconstruction for you and what options are suitable, but your input is extremely important. We'll ask questions about the timing of the reconstruction, whether we're planning an immediate or a delayed breast reconstruction, whether we're performing a unilateral or a bilateral, whether it's going to be one side or two sides. Especially if we're considering an autologous breast reconstruction, a lot of patients are interested in having prophylactic or preventative mastectomies on the other side. And so we always ask you if that's something that you have given any consideration to or something that you're planning. Because if we use the tissue from your lower tummy, we can only do it once. So if we make one breast with that this year, then if you decide you want a mastectomy on the other side in 5 years' time, that option is no longer available to you, and you would have to have a different type of reconstruction at that time. It doesn't mean we have to make two breasts. It just means that if that's something you're thinking about in the long term, it's important to know that we need to know that before we do the reconstruction. We will want to know about any previous or planned cancer treatments. If you've had previous radiation, we want to know about that. We want to know when that radiation finished. Usually we like to have quite a long time interval between the end of your radiation and considering a breast reconstruction. Especially with autologous breast reconstruction, we need to allow that area of your chest some time to heal. The blood vessels that we connect to are in the field of radiation, and so we like to give them some time to recover before we do this surgery. We also like to know if you're planning to have radiation, if you're coming for an immediate breast reconstruction and your breast surgeon has told you that you will need radiation. We generally don't recommend that you have an immediate breast reconstruction. Your own tissue is a very valuable asset, and we do not like to put that asset through radiation. You only have one tummy. Even though some people feel like they have more, there is only one, and we don't want to radiate it. Other things that we'll bear in mind is any previous scars that you have, the scar from your mastectomy, and also any scars that you may have on your abdomen from previous surgery. A major thing we're looking for to see if you have enough fat and skin. Every lady who comes to my clinic tells me she has plenty of fat and skin, but when we look, there's sometimes just not enough there to make a breast. And we're also going to assess the quality of the surrounding tissue. What were the effects of radiation or any other treatments that you may have had? So most people are a candidate for autologous breast reconstruction, but there are a few things that might make your surgeon tell you that this is not a good option for you. The first and most commonest thing is that you're too slim. You don't have enough fat on your lower tummy to make a nice shaped breast. It's also possible to have too much fat, so you can be too heavy. In patients who are heavier, there can be some complications with healing of the wound on the lower abdomen and some problems with healing in the breast. So we may sometimes tell somebody that they're too heavy to have this surgery and recommend that they lose some weight. Patients who have had a lot of previous abdominal surgery, it may not be possible to do this. Patients who have other illnesses, this is a big surgery and you need to be as healthy as you can possibly be. So your surgeon would have to evaluate what your risks might be for having a long and a surgery with a long recovery time and decide if this was a safe option for you. And as I said, if you were planning on having radiation, your surgeon might tell you that autologous reconstruction is not the best option at this time. So the surgery takes between 6 and 10 hours for us to do. That depends on whether we're doing one side or two sides. So usually somewhere around 6 hours to do one side and somewhere between 8 and 10 hours to do a bilateral reconstruction. Most patients will stay in the hospital for 4 to 5 days after the surgery. And usually we tell patients that their recovery time is about 8 weeks. That doesn't mean that you can't do anything for 8 weeks. You'll be out of bed the day after the surgery and you'll walk out of the hospital on day 5, but you won't feel back to yourself until about 8 weeks after the surgery. So if this is something that you're planning, you need to allow yourself this time to recover and make plans for that with work and having some support at home. The only restriction that we place on you is we tell you not to do any heavy lifting more than 10 pounds for 3 months, and we also ask you not to do any formal tummy exercises to allow your abdomen to heal. So the risks of this procedure are risks that go with any surgery, like bleeding or infection or getting blood clots because of a long surgery, or the risks of anesthesia. But these complications are actually extremely rare. Some people are very frightened by the fact that this is a long surgery, but it's actually a very safe surgery. We're not doing anything complicated on the inside, everything's on the outside, and it's really a long surgery because we're doing very fine, intricate work with a microscope. But it's not like having major heart surgery or surgery inside your abdomen. So the risk of having these problems is actually very small. The specific risks that go with this surgery, and this is something that your doctor will talk to you about in detail, the main thing that we worry about when we do a free flap, where we disconnect tissue from one place and reattach it somewhere else, is that when we reattach the blood vessels, that the blood would not flow properly. That's obviously a devastating complication. If that happens, it means that the reconstruction does not work. Fortunately, that's quite rare, and it usually would happen in less than 1 in every 100 patients who have this surgery. But it does happen, and it's not something that we can always predict before the surgery. It's also possible that when we're taking those small blood vessels out of the muscle, that those little blood vessels may not give enough blood supply to the tissue that we move, and that part of the tissue may not be healthy and that it may not survive. That's usually less of a problem. For most patients, that just means that they have to have dressings, and it's a little bit of a nuisance after the surgery, but it resolves itself. In a small number of patients, it might mean that they need to have a second procedure to fix that problem. Fat necrosis is something that happens if part of the tissue that we move does not have a very good blood supply, and over time those parts might form small hard lumps. They're completely harmless, but they can cause concern to patients because obviously any lump is concerning. But again, that's a rare complication and it's usually not a problem. Although we try to leave your tummy muscle behind, we are operating in the muscle. And so even if all of your tummy muscle is left behind, it may be slightly weaker after the surgery. So your six-pack muscles, they're like straps that go on either side of your tummy. And if we make one of those straps weaker, you can get a bulge where your tummy may stick out a little bit more on that side. It's not a true hernia, but it can be uncomfortable, and sometimes people don't like the appearance of it. It happens in a small minority of patients, and those patients will sometimes ask us to fix that with another surgery. And with any autologous surgery, we're making large incisions on your abdomen and on your breast, so there's always a possibility that some of these areas might be slower to heal than others. But again, that's more of a nuisance, needing dressings for a little bit longer. So the main advantages of having an autologous breast reconstruction is that we can create a breast that is natural in how it looks and it feels. Compared to an implant reconstruction, it allows us more flexibility in terms of customizing the shape to your body shape and also to the shape that you would like the breast to be. It allows us to make a breast in a single stage surgery. We don't need to do any stretching of the tissues beforehand. So it's a longer surgery, but it makes the breast. You wake up with your breast reconstruction. Some patients will need a second surgery to tidy things up or to make things more symmetrical, or maybe they want us to do something to the other side. But the actual breast mound is made in a single stage. There's no foreign body involved. You do not have an implant, so you don't have any concerns about having a foreign body and the complications that can go with that. It brings in nice healthy skin and fat, which is particularly useful for patients who have had radiation prior to this surgery. It brings in nice warm tissue. One thing about implants, especially if you live in Canada, is that they don't have blood supply, so they get cold in the winter. But your DIEPs will be nice and toasty. And unlike implants, like Dr. Zong said, we can't avoid implants changing over time, but a DIEP flap or autologous tissue is your tissue. It's part of you. So it doesn't really change over time, except it changes with you. If you gain weight, it gains weight. You lose weight, it loses weight. And it ages in a kind of more natural way with you. The disadvantages all really circle around the long procedure. So it is a longer procedure, it's a longer recovery time, and you have a long abdominal scar. So it's really, you have to put a little bit more effort in at the beginning. Because we're operating in another part of the body as well as your breast, there is always the potential that you could have complications. The more places we operate, the higher the chances of you having complications. So there is a potential for having some problems where we take the tissue. And of course, there's the inherent risk of flap failure. So over the years, we have gotten a lot better at flaps. Previously, when people first started doing microsurgery, about 1 in 10 flaps may not work, but now we're down to less than 1 in 100, and we hope to keep improving that. If you don't have enough tissue on your abdomen, or if for some reason your surgeon tells you this is not an option, there are other flaps that we do a lot less commonly, and these would include taking tissue from your bum, or taking tissue from the inner thigh. These flaps are very much our second choice. They have a lot of disadvantages compared to your lower abdomen, but they are an option for people who cannot have a DIEP flap. And I'm just going to mention briefly the latissimus dorsi flap because it doesn't fit in with either Dr. Zong's talk or mine, so we'll just mention it so that it doesn't get left out in the cold. The latissimus dorsi is a big flat muscle on your back that you can do without if we move it somewhere else. So when we do a latissimus dorsi flap, we take this muscle from your back with a little piece of skin, we leave it attached and bring it through your armpit around to the front of your chest. So it is an autologous reconstruction in that we're using your own tissue, but unlike your abdomen, there isn't enough fat in this flap to create an entire breast. It doesn't have enough volume. So we only use the latissimus dorsi flap as a covering. It doesn't create the filling of your breast. So we use it to cover an implant. So if you're having a latissimus dorsi flap, you need to have a 2-stage procedure. You'll have a permanent silicone implant that will sit under the flap that we take from the back, and you have a scar on your back as well. So in some ways it has the disadvantages of both types of reconstruction. You have a permanent implant and a 2-stage reconstruction, but you've also had to give us a little bit of tissue to cover it. So we generally use this type of reconstruction in patients who've had previous radiation, so they need something more robust to cover their implant, but they can't have an autologous reconstruction. But it is an option for patients who are not candidates for DIEP. So in summary, the main benefits of having an autologous breast reconstruction is that it provides you with a reconstruction that is natural in shape and feel, and it allows us to create a more customized breast reconstruction. So I think that autologous breast reconstruction, compared to an implant, it is a much bigger investment at the beginning because you have to commit a little bit more time to the surgery and to the recovery. But the outcome may be better for many patients in the long term. So that brings me to my patient. My patient is Jamie, and she had a right breast cancer diagnosed in 2013. She had neoadjuvant chemotherapy followed by a right-sided mastectomy and axillary dissection. And she also elected to have a prophylactic or preventative left-sided mastectomy in October 2013. And after her mastectomy, she had radiation on the right side, which was completed in January 2014. So I first met Jamie in June 2014 when she came in a consultation to my office, and we discussed the options that would be available for her. So we discussed both implant-based reconstruction and autologous-based reconstruction. Because she had had a right-sided radiation, she was not a candidate to have a tissue expander alone put on the right breast. She would have required a latissimus dorsi for coverage on that side. And we also discussed reconstructing both breasts using tissue from her abdomen. So we gave her some information so that she could take some time to think about that. Most patients who come to us for the first time, we outline the options for them, but it can be quite overwhelming, all the information that we give you. So we always give you some time to think about it. So she came back to see me in October 2014, and after having a good look at the information that we gave her and doing her own research, she decided that she would like to have an autologous breast reconstruction using her abdominal tissue. And I agreed that this would be a very good option for her. I felt it would give her a very natural reconstruction. So she underwent this surgery in March 2015. This was just over a year following the end of her radiation. And she did extremely well after her surgery and had a 5-day hospital stay. So from a surgical point of view, everything went very well. But we'll have to wait to hear from Jamie to see what she thought of it. So she's just going to come and talk to you about her decision-making and what her experience of the process of having autologous breast reconstruction.
That's great, eh? Dr. O'Neill, thank you very much for giving me the opportunity to share. So, my story. It was a very difficult decision for me to actually go forward with the reconstruction. It took me a lot of time, a lot of research to get to that final place. And it was why I was very fortunate was I had a very good friend who was going through the exact same journey with me at the exact same time, and she was the exact opposite of me. She could not wait to get on the table and have the work done. So that was good for me because it helped me stay balanced and not crawl too far into my hole. She helped me sort of stay a little bit higher and go, let me take the time to make the right decision for myself. So what happened was I went on a life trip. I went to Italy, and on that trip, I quickly discovered that prosthetics were not the solution for me. And I could tell you many stories of what I encountered from looking for my boobs, because I'd be, honey, I can't find them. Where are they? Because at home I had a place for them, and when you're traveling and you're living in a suitcase, that is not the case. But I remember the exact moment when I made the decision that I would move forward with my reconstruction. So I'm going to give you a visual here. So we're in Cinque Terre. I love to swim, so I had 2 sets of prosthetics, which is also a challenge. You have to have a special bathing suit so you can swim. But on this particular day, we were just going to see the countryside. We go on our train trip, we get there, and I see a beautiful ocean and a beautiful beach. And all I want to do is go swimming. So look at my girlfriend who's gone through this whole journey with me as well. And I'm like, what am I going to do, V? So off we went to a bathing suit shop. I'm like, I'm going to get a bathing suit. So I'll just wear the prosthetics that I have. I'll just go up to my waist. It'll be fine. Anyway, we go into the bathing suit shop. I find a bathing suit that's got little pockets in it. I take my prosthetics. I get the suit on. I put the prosthetics into the pockets. I stand there, and they both fall down to here. So I'm like, okay, that's not a solution. I'm not going swimming today. But that was devastating to me, because what I realized is that my life was being controlled by my prosthetics. So that was the moment in time when I decided that I was going to do reconstruction. Then what did I do? So I went to Dr. O'Neill, and we talked a lot. I asked a lot of questions. I think I looked at every single picture that was on the internet to try to see what these new breasts might look like. I did a lot of reading, and what I suddenly realized is that the hard part for me now is that I didn't really understand what my body would look like when this surgery was done. As Dr. O'Neill explained, they're taking from your tummy to recreate here. So that's a lot of scars on your body, and I wasn't sure whether I was ready for that type of surgery, but what I needed to hear was that my surgeon was a skilled surgeon. So I asked her, I'm like, Dr. O'Neill, I don't mean to offend you, but are you good? Can you do this? And she looked me straight in the eye and she said, Jamie, with full confidence, I believe you'll be very, very happy with the outcome. I'm like, okay, let's go. So then, of course, there was many more months before the surgery actually occurred, so I did the flip-flop. Should I do it? Shouldn't I? What am I doing? Why am I doing this to myself? Just live with the prosthetics, all that sort of craziness. And the decision, and again, my friend Kathy helped me to keep moving forward. The night before the surgery, I got a phone call from the clinical nurse asking me if I had any questions. I'm like, I think I've asked every question that I can possibly ask. I've looked at every picture I can possibly look at. No, I think I'm good. I just have one concern. I need to know when I come out of this that no matter how many scars I have, that I will have symmetry, balance, and proportion on my body. This is extremely important to me. So she said, Jamie, when you're in front of Dr. O'Neill tomorrow morning, before you go in, look her straight in the eye and ask her. I'm like, okay, so now you go in, and she's doing all the drawings on my body, so we know what we're gonna do, just like plastic surgery. And I said, Dr. O'Neill, I have a question. I need to know that you can give me balance and symmetry. That is the most important thing. Leave it with me, Jamie. Went through a very long surgery, came out of the surgery, and I remember thinking to myself, oh my God, how bad is this pain going to be? Because I feel like my whole body's been taken apart. And I'm happy to say that I did not have one little bit of pain. I don't even understand that. There is discomfort. You do feel a little bit beaten up. You're walking like this because you're kind of pulled over. But the surgical team told me what I needed to do. I did exactly what they told me to do, and everything went extremely well. Standing here today, I feel much, much more confident. I did try, like I said, the prosthetics were okay, but this definitely for me was the better solution. So I'm very happy with the decision that I made, and I'm very happy with the outcome. If I had any advice, it would be 3 things. Number 1, find someone to hold your hand and support you through the whole process. So that's Kathy for me. Number 2, this is your journey. It's your decision. Don't let anyone push you into anything that you don't want to do and you're not prepared for. So just know that whatever decision you make is the right decision for you. And last but not least, don't be afraid to have the necessary conversations with your doctor. Ask the questions you need to ask, no matter how silly they sound, because it's important that you get that reassurance that you can proceed and that it's going to be a good outcome for you. And that's my story.
So I just want to thank Jamie again for coming. It's very brave to come and talk about your journey, and I'm glad we found your boob.